Thank you very much. I'd like to thank the President of the Council for inviting me to speak. And it's lovely to be able to do this without a mask on after some time. So, the evolving role of beta-2 agonists in bronchial asthma. We are all familiar with patients like this coming to see us with an exacerbation of their asthma. They can be of either gender, of any age, and of any socio-economic class. Interestingly, objectively, the best measure of an exacerbation is a decrease in their peak expiratory flow, or the FEV1, and the frequency of symptoms is a better marker of an exacerbation than the subjective severity of the symptoms the patient describes. We're all of us in this audience very familiar with the treatment of an exacerbation of asthma: high-flow oxygen, nebulized bronchodilators, and systemic steroids. The bronchodilators that we use are classified in this way. I'm talking about now the selective beta-2 agonists, and we classify them according to their speed of onset, which is fast or slow, and their duration of action, which is short, long, or now ultra-long acting. So if we take salbutamol as our prototype, short-acting, fast onset beta-2 agonist, we would compare that with maybe oral salbutamol, which is also short-acting, but slow in onset. Since the 1990s, we have had the long-acting beta-2 agonists, formoterol and salmeterol, which have one important difference in their pharmacology, in that the formoterol is as rapid in onset as the salbutamol, and we'll talk more about that later, whereas salmeterol can take 3 to 5 minutes to exert its full effects. More recently now we have, and particularly targeted at COPD rather than asthma, the ultra-long-acting once-a-day beta-2 agonists. Vilantrol, indacaterol are examples, and they can take up to 15 minutes to exert their full bronchodilator potential. From the very start of the introduction of these drugs, adrenaline was identified in 1900, and alpha and beta properties of the drug were identified. And it was in the 1960s that we developed these short-acting beta-2 agonists that were useful in treatment of asthma. But almost immediately, we started to run into problems. In the 1970s, there was an epidemic of asthma admissions and asthma deaths in New Zealand, which were nicely investigated by Richard Beasley and others, and shown to be related to the non-selective beta-1, beta-2 agonist formoterol, which had been introduced recently to the market. On this slide here, you can see admissions as the black line and deaths as the white dotted line. At point A, a very nice case-control study was published showing the link between the use of formoterol and increased mortality. And in 1990, the drug was withdrawn, and you can see very clearly here that there was an acute and abrupt fall in asthma mortality with the withdrawal of this drug. The idea being that unrestricted overuse of formoterol had in some way, mechanism was not identified, responsible for increased asthma deaths. I'd like to just contrast this with the kind of studies that we are familiar with that show us the other side of the coin, which is the importance of the inhaled steroid in managing asthma. So there are many studies like this. In this study, the y-axis shows improving lung function, and on the x-axis, time. So we take the bottom line, terbutaline, a beta-2 agonist, does improve asthma, and you can see that that improves lung function. But it does not improve lung function as much as the inhaled steroid budesonide if it's given regularly. So at the end of 2 years, which is the horizontal bar here, oops, oh dear, sorry, what have I done? Let's go back. Okay, the vertical bar at 96 days is the end of the 2-year treatment period, 96 weeks. And you can see at that point that the patients on the inhaled steroid have done better than those on regular beta-2 agonist. But then the investigators did something very clever, and they gave one group of patients taking budesonide regular inhaled steroid to continue. The others, they switched the terbutaline to budesonide. And you can see in that last third of the graph, the patients who had terbutaline, their lung function does improve on budesonide, but it doesn't catch up the patients who are on budesonide all the way through. And so in terms of efficacy, what we conclude from this is that if you don't start inhaled steroids early, you lose lung function that you can't catch up on. In 1997, in the New England Journal, the FACET study was published, which told us how to use these longer-acting agents more sensibly. If I can share some of the data with you. This is improving lung function over a 12-month period. The bottom line in red is a low dose of regular budesonide. Improves things. A higher dose in green improves things a little more, but the dose response curve for inhaled steroids is pretty flat. So there's not much improvement. But what there is an improvement is adding in a long-acting beta-2 agonist, and they use formoterol in this case. And you can see that with the addition of formoterol to the low dose, the red line increases to the orange line, improved lung function. And if you add it to the green line, which is a slightly higher dose, not a high dose, we'd call it a moderate dose of budesonide, that increases to the purple line. So a very important conclusion was reached that whatever dose of inhaled steroid you're on, if you add in a long-acting beta-2 agonist, you improve your lung function and you reduce your exacerbations. This is irrespective of the dose of inhaled steroid you're taking. And this was very interesting and helpful, and from the patient's point of view, it was very attractive, because now when they took their inhaled steroid, it contained a beta-2 agonist, and they had some immediate symptomatic improvement, which of course improved their compliance. This led to the combination of 2 drugs in one inhalation that we're now so familiar with, where rather than using 2 separate inhalers, they improve compliance again by putting them all into one dose, into one device. The first fly in the ointment came a few years later with the salmeterol multi-center asthma research trial, which the authors called the SMART study. And we can in a moment decide together how smart we think they really were. This was a comparison of normal, usual pharmacotherapy for asthma or usual pharmacotherapy plus the addition of salmeterol. So try and see whether salmeterol in the real world would improve asthma outcomes. So patients were randomized as described, usual care plus blinded salmeterol or usual care plus a blinded placebo. 13,000 participants in each limb, telling us that this was clearly carried out in general practice, and the study was to run 28 weeks. However, these were the results. Mortality in black on placebo, 3 patients died. In gray, on the active salmeterol arm, 13 patients died. And the upshot of this was that the study was stopped at interim analysis. There was a similar dropout rate in both limbs, so that could not be the answer. And asthma deaths were 4.4 times as likely on salmeterol as compared to placebo. So a clear risk on being on salmeterol. Put another way, it meant that there's one death for every patient treated with salmeterol. So for every 700 patients treated with salmeterol for 1 year, which when you think about the number of patients who are put on salmeterol is a very significant number. What was shocking further about this trial was that it was not clear which patients had been on inhaled steroids and which had not. So randomization to salmeterol had not been stratified as to whether they were on inhaled steroid or not. And even worse, there were apparently no records kept to go back and look and see what patients had been taken. So this was a worrying finding, and it led to a concern about the safety of long-acting beta-2 agonists that resulted in Oh, that's a shame. Okay. That led to what is not here, I'm sorry, a slide is missing, a black box warning in every package insert. Now, a black box warning is I think the second most thing that pharmaceutical companies don't like. I think the thing they hate most of all is having to write to every doctor under their jurisdiction saying, dear doctor, I'm sorry, our drug has been withdrawn or there's a problem. The second worst thing is a black box warning. And this black box warning said, there has been a study with long-acting beta-2 agonists. We think it's a class effect, not just salmeterol. So you are warned that there may be an increased risk of death when using these drugs. So not only do the doctors know this and the pharmaceutical companies know this, the patients are also informed of this. Now, it has been fairly conclusively concluded that the risk is of inhaled bronchodilator beta-2 agonists without the protection of the inhaled steroid. So nowadays, the black box warning has been withdrawn from combination products, but remains still when you prescribe or dispense single-agent formoterol or salmeterol. In 2019, the Global Initiative on Asthma made a landmark change in asthma management, taking these problems with unsupported beta-2 agonists to a further level. And this was for safety, not because of efficacy, for safety. GINA no longer recommends short-acting beta-2 agonists, salbutamol-like drugs, at step 1 for patients who have on and off intermittent symptoms. They said short-acting beta agonists only increase the risk of severe exacerbations, and adding any inhaled corticosteroids significantly reduces the risk. So all adults and adolescents with asthma should receive an ICS-containing controller treatment to reduce the risk of serious exacerbations. That means that ICS can be delivered regularly by daily treatment in mild asthma, or for even milder asthma as needed in combination with an inhaled steroid. So inhaled steroids and a long-acting agonist together rather than salbutamol by itself. So the new guidelines look like this. Look at step 1. The as-needed treatment is low-dose inhaled steroid formoterol. Not even inhaled steroid salbutamol, because as I indicated earlier, these drugs both have a rapid onset of action, but the formoterol lasts much longer, so you get longer protection than you do if you take a salbutamol combination. What is the evidence for this? In one trial they cite, and this is Richard Beasley again after his pioneering work on formoterol a few decades earlier, 668 physician-diagnosed asthma, followed up for a year, either randomized to salbutamol as required, fixed-dose budesonide with salbutamol SOS, or a combination of budesonide formoterol as required. And the results were presented in two ways. On your left-hand side, annualized exacerbation rates. The gray bar is salbutamol as required, and you can see that there's a significant improvement with either the budesonide maintenance or the budesonide formoterol as required group. No difference between those two, but either of those two are significantly better than salbutamol by itself. On your right-hand side, the same data presented as time to first exacerbation. The gray line along at the bottom of the graph that steeps more deeply is salbutamol on its own, and you can see that there's relatively better protection from taking either maintenance budesonide or the budesonide formoterol combination. So, if someone has mild asthma, we would give them a low-dose inhaled corticosteroid and give them separately an as-needed low-dose inhaled corticosteroid formoterol combination to keep in reserve. If they have even milder asthma, where they just use it a couple of times a month, maybe seasonally, we would not give them salbutamol anymore. We would give them as needed, low-dose inhaled corticosteroid, and that is the generic. It could be budesonide, it could be fluticasone, it could be any number of products combined with the formoterol. So we come back to our patient who has an acute exacerbation of asthma, and you may think that one of the last places left for single-agent beta-2 agonist is in this situation where this patient will be given nebulized salbutamol 5 milligrams in 3 mL of normal saline over 5 minutes. And we see patients like that every day. They come at 6 o'clock in the morning with their worsening symptoms. You nebulize them with salbutamol, and they say they feel better, and they go back off to work. But the problem there is, if that is all you do, they will come back the next night and the next night. And so even in this situation, we know that if we really want to deal with their problems, we must give them 30 milligrams of prednisolone and say, take this for 5 days, go and see your family doctor or your specialist, and make sure you're on adequate protection. Thank you very much.